All right, getting into some orthopedic imaging today. We're using Ortho Made Simple from a website, mokyingren.sg.
Oh, nice.
It's written by Dr. Mokyingren.
Okay.
He's a sports surgeon over at National University Hospital in Singapore.
Cool.
And actually, just last year in 2022, he aced his FRCS. So
Wow.
this is going to be a good one.
Awesome.
This deep dive, we're going to be going through a lot of the essential imaging techniques.
Absolutely.
And, we're thinking about things that are really essential for those big exams.
Yeah, the exit exams, FRCS, all that. It's
Exactly.
the gutter stuff.
So we'll cover, your MRI, your X-ray and CT, ultrasound, nuclear imaging.
Yeah, the whole gamut. I think, it's one thing to recognize the images, but really understanding what the images are telling you. That's the key.
Absolutely. And that's what we're hoping to get to today.
Yeah.
So, that said, let's get started with, it can be a little bit of a black box.
Yeah.
But MRI.
Oh, MRI. Yeah, I think it can be quite daunting when you first look at it.
Yeah.
All those, beautiful, detailed pictures. But what's actually going on behind the scenes?
Yeah. How does it even work?
So basically, MRI, what it does is it listens to the behavior of the protons within the body's water molecules. So we place the patient in a strong magnetic field, which aligns all these protons, and then we hit them with radio waves to disrupt that alignment, right? And by measuring how quickly they realign, we can get all this really detailed information about the different tissues.
It's just incredible, that we kind of get all this information about, the human body.
It is.
From listening to these little tiny protons.
Yeah.
So when we're looking at an MRI scan, what are some of the key things that we as, budding orthopedic surgeons should really be focusing on?
All right. So first things first, you need to understand the difference between T1 and T2 weighted images. Think of it as different filters that highlight different aspects of what you're looking at. So T1 weighting, that's your go-to for anatomy. It shows you the structures.
Okay.
Bones are bright white. Muscle is gray, fat is bright. T2 weighting, on the other hand, is your pathological detective. It's super sensitive to fluid. So anything inflamed, swollen, or containing excess fluid is going to light up like a beacon.
So if I see a big bright blob on that T2, image of a knee, that's
It's screaming at you, hey, check me out. There's inflammation here.
Yeah.
Exactly.
Something's going on.
And that could be, a torn meniscus or ligament injury, even early signs of arthritis.
Yeah, makes sense.
But here's the catch, right? Sometimes those bright signals can be a bit misleading.
Oh.
Especially when it comes to tendons. You remember the magic angle effect?
Oh, yeah. Yeah, isn't that the one where a tendon can look bright on a T1 even if it's not actually torn?
Precisely. You see this often in the shoulder, particularly with the supraspinatus tendon. So the angle of the tendon relative to the magnetic field can actually create what we call a false positive, right?
Okay.
So always, always correlate your imaging findings with the patient's symptoms and physical exam findings. If they've got no pain, no weakness, that bright signal might just be a trick of the light.
Okay, so it really is, putting all the pieces together.
Yeah.
And kind of being a little bit of a detective,
Exactly.
Now, I remember, one of the things that was really drilled into us when we were learning about MRI was, contraindications.
Oh, absolutely.
Right.
I mean, safety first, right.
Yeah. Well,
So MRI safety is paramount. The big one, of course, is cochlear implants.
Yeah.
The magnetic field can really damage them, so it's a hard no.
Yeah.
Certain pacemakers, metal implants might be okay, but it requires really careful evaluation.
Yeah, for sure.
You got to make sure it's safe.
So, sometimes we need to give a little boost to those MRI images.
Yeah.
And we do that with what's called a contrast agent,
Right.
gadolinium. What's the deal with that?
So gadolinium, it's like a little helper that allows us to visualize blood vessels and inflammation more clearly. It's really helpful for highlighting subtle lesions or, assessing the vascularity of a particular area. But there's a catch, right? There's a rare but serious risk of nephrogenic systemic fibrosis.
Oh, wow.
It's a condition that causes fibrosis of the skin and the organs. And this can happen in patients who have kidney problems.
Okay, yeah.
So checking kidney function before you give gadolinium, absolutely crucial.
Right, so it's always about, weighing the benefits with the risks.
Absolutely.
And making sure it's the right thing for the patient.
Exactly. It's all about patient safety.
Now, speaking of risks and benefits, let's move on to another imaging workhorse. X-rays.
Ugh. Good old X-rays are bread and butter. quick, cost-effective way to assess bones and joints.
Yeah.
And it really comes down to how much radiation different tissues absorb. So denser tissue, like bone, they appear brighter because they absorb more radiation.
Yeah.
Whereas softer tissues, like muscle, appear darker because they let more radiation through.
Okay, so it's almost like, shining a light through.
Yeah, it's a good
There's
analogy.
different materials and somewhat more light through than others.
Absolutely.
But how do we actually quantify that difference in absorption? Is there, like, a way to measure that?
So we use something called Hounsfield units. And we use water as our reference point, right?
Okay.
So water has a Hounsfield unit of 0.
Okay.
Bone, being denser than water, has a positive value, while air, being less dense, has a negative value.
Makes sense.
So this gives us a standardized way to compare images and to assess those subtle density changes.
So it's like a universal language.
Yeah, it's a universal
Like for X-ray density. I've always been fascinated by how we use X-rays, to take things a step further.
Yeah.
And use for, what we know as CT scans.
CT. Yeah.
How do we go from, a simple X-ray to this, like, almost three-dimensional image?
Right. So basically a CT scan is like taking multiple X-ray slices from different angles, and then a computer stitches them together like a jigsaw puzzle to create that 3D model.
Wow.
And this allows us to really visualize, complex fractures, joint anatomy, even internal organs, in really amazing detail.
So we can see, like, those little tiny bone fragment, or like, assess that alignment of a joint so much better than we can with just a plain X-ray.
Much more precisely. Absolutely.
Now, talking about X-rays, you can't really, not talk about X-rays in the operating room.
Yeah.
Those image intensifiers.
Yeah, they're crucial.
Really important.
For guiding procedures like fracture fixation, putting in implants. Really important.
Absolutely. But with all of this X-ray talk, we have to think about radiation safety.
Oh, absolutely. Especially in the OR.
Yeah.
Where everyone's exposed. You got to be really careful.
So what are some key principles to keep in mind, in terms of keeping ourselves safe?
So it all boils down to time, distance, and shielding. So you minimize the duration of exposure, you keep a safe distance from that X-ray source.
Okay.
And you use those protective barriers like lead aprons, thyroid shields.
Yeah, for sure.
Teamwork, communication is vital to ensure that everyone's safe.
Yeah, you're absolutely right.
We look out for each other.
Now, before we move on to some of the other imaging modalities, I do want to touch upon another application of X-rays.
Sure.
And that's a DEG scan.
Oh, yeah.
So these are specifically designed for measuring bone density, right?
Exactly. DSI stands for Dual Energy X-ray Absorptiometry.
Wow, that's a mouthful.
It is a bit of a mouthful, right? But essentially what it does is it uses two different X-ray energies to really differentiate between the bone and the soft tissue.
Okay.
So it gives us a very precise measurement of bone mineral density.
So this is our kind of go-to test if we're thinking about, somebody's bone health.
Absolutely.
And, we're worried about things like osteoporosis.
Exactly. Particularly important, as patients get older.
Yeah, absolutely.
So DXA scans are crucial for identifying individuals at risk of fractures and guiding our treatment decisions. We typically focus on the lumbar spine for these measurements, and we calculate the average bone density to assess overall bone health.
Makes sense.
But, I've heard that those DXA scores can sometimes be a bit misleading.
Oh, really? What do you mean by that?
Well, there are certain conditions like arthritis or previous fractures that can actually lead to falsely elevated bone density readings.
Okay.
And conversely, things like scoliosis or if someone's got spinal hardware, that can falsely lower the readings.
So we really got to look at, the whole picture.
The images themselves, consider the patient's clinical history. Don't just rely on that number.
Yeah.
You got to put it all together.
It's another reminder that, imaging is just one piece of the puzzle.
One piece.
Absolutely.
It's not the be-all and end-all.
Now, let's switch gears and let's go from radiation to sound waves.
Oh, sound waves.
And explore the world of ultrasound.
Ultrasound.
It seems to be becoming more and more popular in orthopedics.
Yeah, it's a fantastic tool.
Yeah.
Especially because it's so portable.
Yeah.
You can bring it to the bedside. Real-time imaging, can't beat that.
I love that we can see things happening in real time.
Yeah.
You can see like a muscle contract. You can see, tendon movement.
It's amazing, isn't it?
But how does it even work? you know?
So it's all about how sound waves interact with different tissues.
Mm.
So the ultrasound machine emits high-frequency sound waves. They travel through the body. They encounter these different tissues.
Oh, okay.
And when they hit a boundary between two tissue types, some of them are reflected back to the transducer, creating an echo.
Oh, so it's almost like sonar, you know?
Yeah.
We're sending out these waves, and then we're
Exactly like sonar.
listening to the echoes that bounce back.
You got it. And by analyzing those echoes, the machine creates an image based on the time it takes for the sound waves to return
Okay.
and their intensity.
So different tissues.
Different tissues reflect sound waves differently.
Okay.
And that's what gives us those valuable information about their structure and composition.
So, you know, a fluid-filled cyst, for example, won't reflect a lot of sound.
Yeah.
So
It'll appear dark on the ultrasound image.
okay, whereas, you know, something like a tendon, which is quite dense, would appear brighter.
It will appear gray.
So it's like having a built-in contrast agent, almost.
Absolutely. That's a great way to think about it. And then we can even use, something called the Doppler effect to assess blood flow.
Oh, the Doppler effect.
Yeah.
You know, like when you hear an ambulance siren, and it's like...
Exactly, that change in pitch as it passes by.
Yeah.
It's the same principle. By analyzing the changes in frequency of those reflected sound waves, we can determine the speed and the direction of blood flow in the vessels.
So we're getting, you know, not just structural information, but we're also getting functional information.
Absolutely. It's a really powerful tool
Yeah, very cool.
for technology that just uses sound waves.
All right. Well, we've covered, you know, 3 major imaging modalities so far.
Yeah.
MRI, X-ray, ultrasound.
Nice.
I think it's time to move on to a quick overview of nuclear imaging,
All right, nuclear imaging.
which, you know, it's a little different.
It's a different approach.
Yeah. So how does that one work?
So nuclear imaging relies on radioactive isotopes that are introduced into the body.
Okay.
And these isotopes emit gamma rays, which are then detected by a special camera to create those images.
So we're not using, you know, like in MRI, we're using magnetic fields. With ultrasound, we're using sound waves.
Yep.
Here, we're actually using something internal
Yeah,
to kind of help us visualize these things.
we are. It's like giving the body a tiny little flashlight that highlights areas of interest.
Okay.
And one of the most common applications in orthopedics is the bone scan, where we use a tracer that binds to areas of active bone turnover.
Okay.
Remember, this is the process of bone remodeling, where old bone is broken down and replaced with new bone.
So it kind of highlights those hot spots where the bone is being really active.
Exactly.
And that can help us, you know, diagnose all sorts of things.
Absolutely, from fractures to infections, tumors, arthritis, anything that disrupts that normal balance of bone turnover will show up on a bone scan.
Okay.
So it's a pretty versatile tool.
It is. It is.
Yeah. Welcome back. Still going strong with our orthopedic imaging deep dive.
And, you know, we're still using Dr. Mokyingren's Ortho Made Simple notes.
Oh, yeah, they're great.
Really helping us, you know, really get into the
Yeah.
nitty-gritty of these concepts that we need to know.
Absolutely.
So we've done a lot so far.
We have.
I've done MRI, we've done X-ray, we've even talked a little bit about ultrasound.
Yep.
But I think it's time that we delve a little deeper into nuclear imaging.
All right, let's do it.
And specifically, those bone scans.
Bone scans, yeah, they're really interesting.
They are.
They give us a unique window into the metabolic activity of the bone.
Yeah.
Remember, we're using that radioactive tracer
Yeah.
that seeks out areas of active bone turnover, those hot spots where bone is being broken down and rebuilt.
So it's not just showing us, you know, the structure of the bone.
No.
It's showing us what's actually happening at like a cellular level.
Exactly. It's showing us the function, the activity.
Yeah.
And this is where it gets really interesting. Bone scans are typically performed in 3 phases: flow, blood pool, and delayed.
Okay, now hold on. Break that down for me.
Sure.
What are those 3 phases actually showing us?
Okay, so the flow phase, it's captured immediately after we inject the tracer.
Oh.
And it shows us the blood flow to the bones.
All right, so like perfusion, basically.
Exactly, perfusion.
Okay, and then the second phase.
The blood pool phase. This one's taken a few minutes later.
Yeah.
And it highlights the distribution of the tracer within the blood vessels of the bones.
So it's showing us like where the tracer's hanging out
Yeah, where it's pooling, basically.
in the blood vessel.
Exactly. And then the delayed phase, that one's taken a few hours later.
Okay.
And this shows us the areas of increased tracer uptake, the areas where the bone is really active.
Okay, so it's almost like a time-lapse video, right? We're seeing how the tracer moves through the bones.
It is.
And then where it ultimately kind of concentrates.
Exactly. And by analyzing the pattern of uptake in these three phases, we can differentiate between different conditions.
Okay, so give me an example. Like, how would a stress fracture
Okay.
look different from, say, osteomyelitis on a bone scan?
Great question. So a stress fracture, which is essentially a tiny crack in the bone, right,
Yeah.
will typically show increased uptake in all three phases,
Okay.
particularly in that delayed phase.
Okay.
Osteomyelitis, on the other hand, often presents with very intense uptake
Oh, wow.
in all three phases because there's so much blood flow and activity going on in that area of infection.
So if I see those three phases just lighting up,
Yeah, that's a red
I
flag.
gotta think infection.
Definitely got to think infection. But here's where it gets tricky, right?
Okay.
Some very aggressive cancers can actually appear as cold spots on bone scans.
No, wait a minute.
Yeah.
That doesn't make sense.
I know, it's counterintuitive.
Because cancer, you think lots of growth, lots of activity.
You'd think so, right? But in some cases, the cancer cells are destroying the bone faster than the body can make new bone.
Okay.
So that leads to a decrease in tracer uptake.
So it's like a wolf in sheep's clothing.
It is. It is. It's a cold spot that's actually really bad news.
Oh, wow. Okay.
So always correlate your bone scan findings with the patient's history, other imaging, the whole picture.
Absolutely. It's all about putting the pieces together.
Exactly.
All right. Well, let's switch gears a little bit and talk about another type of nuclear imaging that's, kind of revolutionized how we think about cancer. PET scans.
Oh, PET scans. Yeah, they're amazing.
So how do they differ from bone scans? Because I always get a little confused.
Sure. So bone scans focus on bone turnover.
Mm.
PET scans take a broader view. They look at the metabolic activity of the whole body.
Okay.
They use a tracer that's tagged to glucose,
Okay.
the primary fuel
Yeah.
for cells, right? And cancer cells, they're hungry, they're metabolically hyperactive.
Yeah. They're greedy little things.
They are. So they gobble up this glucose tracer like there's no tomorrow.
So the areas that are really active, like tumors,
Yeah.
they just light up.
They light up like a Christmas tree.
Yeah. And the cool thing is we can combine PT scans with CT or MRI. So we get those detailed anatomical images
Yeah.
along with the metabolic information.
So we know exactly where things are.
Exactly. We can pinpoint the location, the extent of tumors, see how aggressive they are.
Wow. It really is like having a superpower, isn't it?
It is. It's like seeing the body's secrets.
Yeah.
P scans have become absolutely essential in oncology.
Yeah, definitely.
They're helping us make better treatment decisions, improve patient outcomes.
Now, before we, wrap up this section, I want to go back to ultrasound for a second.
Okay, ultrasound, sure.
We talked about, how portable it is,
Yeah.
how we can get those real-time images.
Real time, that's the key.
Right. But what are some specific applications in orthopedics? Like, what are we actually using it for?
Oh, so many things. We use it to guide injections
Okay.
into joints, tendons.
Mm.
We can assess for tendon tears, inflammation, diagnose carpal tunnel syndrome.
Even screen infants for developmental dysplasia of the hip.
Wow, it's like a Swiss Army knife of imaging.
It is. It's so versatile.
But I imagine there are some limitations, right?
Of course, no imaging modality is perfect.
Yeah.
Ultrasound, it doesn't penetrate bone very well.
Okay.
So it's not ideal for visualizing structures deep within the bone.
Yeah, makes sense.
And it can be challenging to get good images in patients who are obese or those with a lot of soft tissue swelling.
So again, it's about choosing the right tool for the job.
Absolutely. And that's why it's so important to really understand all these different imaging modalities.
Yeah.
Not just for your exams, but for your future practice.
Yeah,
Because
absolutely.
you're going to be using these tools to make decisions that impact your patients' lives.
It's a big responsibility.
It is, but it's also incredibly rewarding.
Yeah, absolutely.
And, thanks to Dr. Moak's notes,
Yeah,
we're well on our way to mastering these concepts.
absolutely. Ortho made simple.
Yeah.
Really living up to its name.
It is.
Making things so much easier for us to understand. Welcome back to our orthopedic imaging deep dive. We've learned so much from Dr. Mokyingren's Ortho Made Simple notes.
Yeah, let's put all that knowledge to the test.
Okay, get ready for some cases. They're going to help you sharpen those imaging interpretation skills.
All right, hit me.
Okay, first case. You're in the ER. 25-year-old basketball player comes in with severe ankle pain. He landed awkwardly, can't bear weight, and the ankle is super swollen. What imaging are you ordering and what are you looking for?
All right, so first things first, got to get an x-ray of that ankle.
X-ray. Makes sense.
Definitely want an AP and a lateral view.
2 views to really see what's going on.
Exactly, got to cover all our bases. On those x-rays, we're looking for any disruption in the normal alignment of those ankle bones.
So the tibia, fibula, talus, the whole crew.
The whole gang's there. We want to rule out any dislocations or fractures, looking for any lucent lines or cortical disruptions. Oh, and don't forget to look at the soft tissues, too.
Oh, right. Swelling can be a clue even if you don't see a clear break on the bone.
Exactly. Sometimes it's the subtle signs that give it away.
Okay, so let's say those x-rays show a subtle disruption of that talar dome. What's next?
Time for a CT scan.
CT scan it is.
CT gives us much better detail of the bones. It can pick up those subtle fractures that an x-ray might miss, especially in tricky spots like the talar dome.
Makes sense. All right, next case. 50-year-old woman, chronic shoulder pain, trouble lifting her arm, tried physiotherapy, but no luck. What imaging are you thinking?
This sounds like a job for MRI.
MRI, gotta love it for those soft tissues.
Absolutely. For the shoulder, we'd be focusing on those rotator cuff tendons, particularly the supraspinatus, to look for tears or tendinopathy. We'd also want to assess the labrum for any tears or detachments, and of course, can't forget about checking for arthritis in the glenohumeral joint.
So basically a full shoulder workup.
Exactly. We want to see the whole picture.
All right, now the report comes back. Mentions increased signal in the supraspinatus tendon on those T2 weighted images. What does that tell you?
Increased signal on T2 often means inflammation or edema. Could be tendinitis or even a partial tear.
Hold on. Didn't we talk about that magic angle effect, where a tendon can look bright even if it's not torn?
You're right, but that magic angle usually affects T1 weighted images more.
Ah, okay.
If we see that increased signal on both T1 and T2, it makes a tear more likely. But we always correlate with the patient's symptoms.
So if they have pain and weakness, especially when they try to lift their arm overhead, it points towards a tear.
Bingo. Clinical correlation is key.
All right, one last case for you. 70-year-old man falls at home, lands right on his hip. He's in a lot of pain and can't move that leg. What imaging are we getting ASAP?
We need an x-ray of the pelvis and hip stat. Gotta rule out a hip fracture.
Those are always a concern, especially in older patients. What are some things you look for on the x-ray to differentiate between the types of hip fractures?
We look at the location of that fracture line. Is it in the femoral neck, just below the femoral head? Or is it intertrochanteric, between the greater and lesser trochanters? We also look at how much the bones are displaced or angulated. That helps us decide how to treat it.
So the x-ray gives us that initial assessment. But what if it looks okay and the patient is still in a ton of pain and can't put weight on that leg?
Especially in elderly patients, we have to consider the possibility of an occult fracture. Those are sneaky fractures that don't always show up clearly on those initial x-rays. An MRI or a bone scan can help us pick those up and make sure we're not missing anything.
Right. Got to be extra careful with those high-risk patients.
Well, I think that wraps up our case studies.
You did a fantastic job.
These imaging modalities are powerful tools, but they're just one part of the puzzle, right?
Absolutely. We always combine the imaging findings with the patient's history, their physical exam, and our own clinical judgment. Exactly. It's all about putting the pieces together to give our patients the best care possible. Big thanks to Dr. Mokyingren's Ortho Made Simple notes for guiding us through this. Those notes are a gold mine of information for anyone getting ready for their exams and for their future practice. Keep learning, keep asking those questions, and you'll all be amazing orthopedic surgeons. We'll catch you on our next deep dive.